Hi, I'm Steve Simpson, Professor of Pulmonary and Critical Care at the University of Kansas and Director of our Medical Intensive Care Units at the University of Kansas Hospital.
And I'm Roop Powell, Associate Professor of Internal Medicine at KU and a hospitalist at the University of Kansas Hospital.
We're here to talk about severe sepsis, life-threatening organ dysfunction due to a dysregulated host response to infection.
By the end of this video, we want you to be able to recognize severe sepsis when it's present. Recognition is the first step to stopping sepsis in its tracks. So, Stephen, how do we recognize severe sepsis?
Great question. We see sepsis all the time. Providers look at sepsis all the time and look right past it and don't notice it because it is almost so simple. Sepsis and severe sepsis both hinge on the presence of infection. So that's what we're looking for first. Doesn't have to be completely diagnosed, doesn't have to be bacteriologically proven with cultures, has to be a good reason to believe that the patient has it, like purulent sputum with pleuritic chest pain and a cough would define a pneumonia.
Okay, so it starts with infection and the presence or suspicion of infection.
Absolutely. And then what we look for is something called SIRS. SIRS stands for the Systemic Inflammatory Response Syndrome. It's a concept that was dreamed up by an assistant professor right here at the University of Kansas some 40 years ago. The components of SIRS are pretty simple. They are fever or hypothermia, i.e. body temperature is what's important. Fever is defined as a temperature greater than 38 degrees, which in Fahrenheit, I believe, is about 100.3. Or hypothermia is defined as a temperature of 36 degrees, which I believe in Fahrenheit degrees is about 96.8 degrees. Tachypnea, which means rapid breathing rate. If someone's breathing more than 20 breaths per minute, we call that a component of SIRS. Tachycardia, for this purpose we use a pulse rate that's more than 90 beats per minute. And then the last criterion is white blood cell count. We always look at white blood cell count when we're working up an infection or we're suspicious of an infection. So if we see a count that's greater than 12,000, we say that's too high. If we see a count that's less than 4,000, we say that's too low. But if it's in the normal range, we look for the band forms. And then we say if there are more than 10% of those or some other immature neutrophils, that we call that a SIRS criterion. So what we're really looking for to diagnose sepsis is to see an infection and at least two of those SIRS components.
Okay. And that's great. So infection, SIRS. What makes severe sepsis?
Severe sepsis is when that infection leads to a dysfunction of an organ that we can detect in one way or another. And we probably don't have time in this video to go into specific details, but I can tell you from head to toe, we look for central nervous system dysfunction or confusion. We look for cardiovascular dysfunction or hypotension. We look for pulmonary dysfunction or hypoxemia. Renal dysfunction, which would be either low urine output or a bump in creatinine. We look for evidence of DIC, which would be like low platelets or elevated coagulation parameters. Look for liver dysfunction, which would be a high bilirubin, and not the least, we look for lactic acidosis.
And so that helps us better understand severe sepsis. So infection, SIRS, and organ dysfunction.
Absolutely, you got it. And if everyone gets that part down, we will diagnose a lot more sepsis, infection, SIRS, and organ dysfunction.
Excellent. So I think that's all the time we have for this video. We've talked about the clinical features of severe sepsis and how to recognize it. Please join us for our next conversation when we talk about how to treat severe sepsis.
For the University of Kansas Hospital, I'm Steve Simpson with Roop Powell, and we want to help you stop sepsis.